Hello, welcome to another episode of Whiteboard Learning. Today we're going to talk about arrhythmias. And that comes from the word rhythm for your heart rhythm. And R is the prefix like A, and R are they both mean without. So without rhythm. And the hardest part about arrhythmia is spelling it because it has all these extra consonants, which are a real pain. But that's what it means. It means without rhythm. So the heart has a beat or a rhythm. That makes sense. And it is based on an electrical signal that tells the heart when to beat. And that is the basic idea of what happens in arrhythmia is that the electricity of the heart tells it to beat in a different way. And let's talk about that electricity. There's something called automaticity. Sounds to kind of a interesting way of saying automatic, right? Automaticity means that there's a cell that creates an electrical signal by itself. It has its own little electrical signal beater, almost like a metronome. And that's probably a good way to think about automaticity of the heart, is that the heart has a metronome. And the metronome beats and sends out an electrical signal. So if you think about the heart, it's a kind of a simplified way that we kind of think about the heart, is that it's divided into two chambers, and you have the right side and you have the left side, and that's facing you, right? And so we have an atria, which is a thin-walled holding chamber for blood, and then we have the ventricles, which are the thicker-walled pumping. And we're not really going to talk about where they go. We're just going to talk about the fact that they pump and that they are, it's a heart muscle. So we have our atria and we have our ventricle. So much about arrhythmias is based on the cells that create the signal for the heart to pump. And it's elegant and complex. We have a little pacemaker starting here. That's the sinoatrial node, and those cells have an automaticity atrial node, and they have an automaticity of maybe in a big dog or a human might be 60 to 100 beats per minute. And that might be different for a bird. A bird's going to have a starting heartbeat that is maybe 200, or a rabbit. So different SA nodes in different species are going to have a different primary beat generator or metronome. And that is the predominant beat because it's beating the fastest of all the cells in the heart that might have their own automaticity. Because each of these cells in the heart actually can decide when to beat or contract or do things on their own. But they all beat at different rates. And the SA node is the driver because it has the fastest rate. So when the SA node is on its beat, it will generate an electric wave that comes out of it and spreads across the atria all over. Think about it kind of like a powerful wave of like a water rushing across, or electricity or energy. And that will go to the AV node, A meaning atrioventricular, and that is a node or bundle of cells right here that receive that signal, and that tells it to beat. And it has a slower automatic rate. Maybe that would be 40 to 50. So if the SA node went away, you would still have automaticity, but your heart rate would be slower. And so then that bunch of cells signals out through some fibers, and they run along this interventricular septum, they call it, between the two cells. So maybe in the beginning it's sort of a thick area, and you hear that called the bundle of His. And then they break off from each other, and it's called bundle branches. So you'll have a left bundle branch and a right bundle branch, and then they'll go into the muscle of each side, and that'll be what are called Purkinje fibers, and it'll go into the actual muscles of the ventricle. So this, while it's kind of an island by itself, the AV node leads to the other fibers that have their own automaticity. So as you go further down, all of these cells have automaticity, but maybe it will be slower. So if we took away the SA and the AV node, these little ventricle cells would decide to maybe beat at 30 beats per minute, but they would still beat on their own. And that's the definition of automaticity, that automatic electrical signal that they will generate to the other cells. So with that automaticity and this electrical wave of signals, you create an electrical field. And that is what people see and think of with the EKG is your PQRS T complexes. And I'm going to also send with the video for this a website that goes over a lot of this in better definition so that you can look at some more and talk about it. But let's do it very quickly, kind of what these are. Now you remember that, you have that little diagram of where the leads are, and if you have leads and you have a heart in the middle and electricity is going in one direction and then in another direction, these are all fields. And this electrical signal in lead 2 looks like this, but it doesn't mean that it looks like that if you look at it from different field directions. So that's why we always talk about lead 2, is because it'll create one that looks kind of like the classic EKG signal. So the P wave is when the SA node beats out to the AV node, and that causes polarization into the atria and contraction of the atria. And then the QRS is when it's coming across the ventricle and it kind of goes out and back and forth, and that's all that really is of the electrical signal creating a wave of energy in specific directions. And then the T wave is repolarization, and that's when the electricity gets to, and the muscles get to basically bring all of the elements back to neutral that they had already set up for contraction, like all the pumps, the calcium and everything have to repolarize to get to be normal. So why is this important? Well, sometimes there'll be what we call an ectopic, kind of like the sad ectopic pregnancy. There'll be an ectopic beat generator. And that is the most common situation in critical care medicine that we deal with, is that there might be a guy over here that decides that it's not going to follow in the wave of energy. It's going to beat on its own. And so when it does, it looks weird. And so you might think of the classic beat that looks wide and bizarre. And when it's wide, it means it comes from the ventricle, usually. If it's narrow, it's coming from above the ventricle. But that would be a VPC, or a ventricular premature contraction. So somebody over here who isn't supposed to be the metronome of the heart is deciding to beat. And why that's important is there's a lot of critical care patients who are at risk for an abnormal beat. And another time we can talk about all of the other kinds of things like blocks, first degree, third degree, whatever all those are. We can talk about that. But today I just want to talk about some of the reasons why we have to be very, very careful in our critical care patients because they may not come in as heart patients, but they become heart patients. So let's talk about that. So one of the ways you can get an ectopic beat is if you get trauma to the heart. So how would you get trauma to that point of the heart so that it has a little problem? Well, if you're human, you might have a stroke, right? And that part of the muscle isn't working anymore. But this could be actual trauma. So you could have been hit by a car and have chest trauma. So any patient who's hit by a car or has a fall or other trauma like that, pretty significant trauma, could have a contusion on their heart. That way, that's why we watch after somebody's been hit by a car. So let's put that on our list of diseases to watch. We watch an EKG for about 24 hours. after they're hit by a car if they have significant trauma. So what does that mean? That might mean that you see pulmonary contusions, and you might have rib fractures or a pneumothorax. So we're talking about significant trauma most of the time. We're not talking about a little bump or a scratch or things like that. So how else could that happen? Well, you could have a situation where you've done surgery. So maybe it's surgery. So any patient that's had a thoracotomy and you've actually been in there and playing around with the heart or the nerves to the heart. So those are all sort of more direct. Then there's sort of the indirect ways, and those are a little harder to understand. So definitely if you had the heart affected by chemicals outside, and then it'll let this little guy have increase in its ability to take over the pacemaker. So that could be some sort of stroke from somewhere else. So where would the else be? Well, usually that would be from the abdomen. So anything that's sort of happening in the abdomen. So one of those things could be a splenectomy. So dogs that have a splenectomy for any reason in the literature have anywhere from a 1 to 10% chance of having a ventricular arrhythmia, so either some beats or an actual really bad arrhythmia like ventricular tachycardia, where only this guy is beating and it's beating so fast that your patient has a high heart rate, or maybe it's beating so fast that the heart never gets a chance to fill and they have low blood pressure. If you're a hemoabdomen or blood in the abdomen splenectomy, you're up to maybe 40% going to have the potential to have ventricular tachycardia or VPCs after surgery in the literature. So let's put that on our list too. So hemoabdomen or splenectomy. And they think that there's a few reasons why this might happen. It might be a stroke, but they also think that the splenic nerve, so you're transecting that when you're doing surgery, may have some sort of effect on the automaticity of the heart, maybe a change in vagal tone that affects things, or there might be chemicals released. They used to say myocardial toxin factor was something that might be released, which might be nitric oxide. It's kind of an old-fashioned way to talk about it. So what else? Other abdominal surgeries? Yes. So any liver, adrenal, any of those things might also. Adrenal glands sometimes are pheochromocytomas, which release norepi. And norepi definitely can affect the automaticity of the heart. Just as we watch when we give blood pressure agents, we watch for ventricular arrhythmias. So we might be on a drug like a pressor that could do it. Or we could say other abdominal surgery is on our list. What else affects the spleen indirectly? So back to hit by car, what if you had hemoabdomen? One of the most likely organs to bleed is the spleen. So if you have hemoabdomen from hit by car, you certainly might have a ventricular arrhythmia. The other thing is GDV. So gastric dilatation and volvulus, or bloat. The spleen can get torsed and injured. The stomach itself can, as it's twisting, so here's I'm going to draw another bad dog picture. Front legs, back legs, tail, real bad. If your stomach is twisting and it goes to the small intestine, as it twists, your spleen is pulled and sometimes the vessels rupture and the spleen gets injured. So GDV is another one that we will watch very carefully. One of the ones that we've seen recently that we've had a lot of trouble with are chocolate dogs. So I certainly don't want to leave that out, or other toxins. But chocolate, we've seen a lot of ventricular arrhythmias afterwards, probably due to an injury to the heart again, kind of like a drug. That caffeine and theobromine, which are the major stimulants in chocolate, are causing an injury causing a cell to decide it's the major one. So this is more of an alert to you, not necessarily a lesson on arrhythmias, but an alert to you that we may have patients who have arrhythmias and we need to keep an eye on it. So general protocol for any of these patients, hit by car, thoracotomy, abdominal surgery, hemoabdomen splenectomy, anyone on pressors, a GDV, is that we are very, very careful to watch them in the first 24 hours for ventricular arrhythmias. Ideally, that's with constant, continuous EKG. But if you do Q4 to 6 hour checks, that can be okay. In people, they have proven that that doesn't stop you. It may make you miss some things, but to be honest, it's been pretty good for me, for dogs, especially if you have any high heart rate. So let's say you go to do your TPR and your P is 170. Well, certainly you're going to go run an EKG. You're not just going to say, oh, the dog's just anxious. Oh, the dog is, maybe it's in pain. I'm going to give it more pain meds. You want to run an EKG to make sure it's not a ventricular rhythm. Well, I hope that was somewhat helpful about what we're watching out for with some of our critical patients. Thank you.